So I'm Zheng, come from University of Bern, working a long time with Klaus and Maurice's group. So today I will talk about advanced medical image computing tools for quantify hip deformity. So everyone knows here that the morphological deformity leading to pain, limitation in activities, and also early osteoarthritis like DDH and FAI. I think imaging technology like radiograph, CT, and MR are often used for diagnosis and intervention. However, for clinical routine usage, they are constrained. Their usage in quantitative measure of femur acetabular morphology are constrained by time-consuming and error-prone manual segmentation. So today I would like to share with you our experience on developing advanced medical image computing tools for quantify hip deformity. I will talk about like fully automatic hip CT segmentation, hip MR segmentation, radial scan, fully automatic segmentation, as well as the hip articular cartilage segmentation and dynamic mapping. So let's move on to the first one. So we developed a fully automatically hip CT segmentation program to quantify hip deformity. The challenge for automatic hip CT segmentation is due to the data heterogeneity because the length of femur in the clinical data is different from scan to scan. And also due to the diverse image quality. You have a low-dose CT scan with implants and also pathology. Also the data size is quite large. Usually it's 512 and by about 150 to 350. As you can see here, there are some, like this one is implant, this one is with the pathology. So we developed a program called Hip CT Second program, which is installed in orthopedic department in the hospital for routine clinical usage. And actually last year, we also successfully licensed this software to 2 companies. If any one of you want to use this software, you can contact me, we can license to you. So basically the idea behind this program is actually we use machine learning for fully automatically organ detection and then combine with the multi-atlas segmentation constraint graph cut. We use the graph cut to reduce the computation time, and also our software can handle images with metal implants, pathology, and low-dose acquisition protocol, as you can see here. We can reduce the segmentation efforts from manual, like say hours, to just like 10 minutes, which is actually fully automatic. You just drink a coffee and you got the segmentation. So actually from Klaus' department, Dr. Lerch, he did evaluation. He took 51 hips with various deformities that tended to purchase deformity, 16 FAI patient and 13 control group. So basically he found with taking the manual segmentation as ground truth, the mean surface distance is 0.3 millimeter for femur and for pelvis is 0.4 millimeter. And he also looked at the diagnostic parameters, like inclination is about 0.8 degree on average, and anteversion is 0.6 degree. And then we also use our FAI impingement software to look at the range of motion. So basically, he found that the mean difference for flexion is 2.2 degree, and the mean difference for extension is 1.9 degree. So this software actually also extends to other structure like knee, shoulder, as well as ankle joint. So that's actually the first work. The second work is focused on fully automatic segmentation hip MR images. So everyone knows due to the acquisition time and also in order to reduce artifacts, so usually the clinical routine uses limited field of view hip MR images. And that's why it's quite challenging to do the fully automatic segmentation. Until now, in the literature, only a few deformable model-based or statistical shape model-based method exist. So here's a flow chart in our method. So basically taking from this limited view of the data, we first do a multitask landmark detection, use the recently introduced the deep learning technology, and then based on detect landmark, we can crop the data to the acetabular region and the femur region. And then we use another deep learning based technology to do fully automatic segmentation. So here it shows the architecture. If you are not familiar, it doesn't matter because this is usually for the people working in our field. The architecture of our network, how to do the multitask landmark detection, and this is the architecture of our network, how to do fully automatically segmentation with multi-level supervision. So here shows actually in different classifier how the probability map look like. As you can see, in the lower classifier it's very sparse, while in higher level classifier it's very accurate. So we did an evaluation study, take 25 T1 weighted unilateral hip joint MR images of AI patient. We did the leave 5 out class validation. Like everyone, we do data augmentation and also sample the patches, pass through our network in order to get the fully automatic segmentation. We evaluate our method with following metrics like dice, Jacquard, precision recall, as well as the surface distance, like average surface distance and modified Hausdorff distance. Here shows the results. For the proximal, we get the dice about 0.989. Basically, if you have perfect segmentation, dice will be 1.0. If you have no overlap, basically 0. As you can see, this is very accurate for both the femur. Also for the acetabulum, we got dice coefficient is 0.977. If you look at the distance, basically compared to the manual segmentation, the average surface distance is 0.11 millimeter for proximal femur, and for the acetabulum is 0.21 millimeter. Here shows the quantitative results. So this is the ground truth. This is predict, and this is the color-coded error map. As you can see, only a few small locations, there's some slightly large error. So this actually software implemented in TensorFlow based on the deep learning framework, and basically it takes only 2 minutes to process one volume after the training. The third work is actually focused on to segment proximal femur from hip radial scan. So I think everyone here knows hip joint poses a unique challenge for MRI imaging. So when conventional imaging plane are used, particular volume averaging will affect substantial, they hamper the depiction of cartilage and labellum damage at the MRI imaging. That's why I think people think about using the radial imaging. So here actually shows the radial imaging, and this is actually every slice. So the segment radial hip MRI is a difficult task due to the unconventional imaging plane, which usually people develop method for the standard Cartesian coordinate-based method, while here is scanned radially. So that's why most of the work based on semi-automatic segmentation. We are aiming to develop the fully automatic solution. So here is our pipeline. So basically, it's starting from the space transform. We transform a radial scan to a Cartesian coordinate, and then use deep learning-based method to do the fully automatic segmentation. So here shows the after space transform. Now it's actually not anymore radial scan. It's like a Cartesian coordinate, but unfortunately the data is extremely fuzzy. As you can see, after interpretation, you probably can identify femur, but other structure is quite challenging. So can we segment, get accurate segmentation from such data? The answer actually yes. This is our network structure. I will not go to details. This actually shows basically, like say this is the input data, and here's probability map. This is our segmentation. This is automatic segmentation. This is the ground truth. This is one view, and this is second view, and this is another view. As you can see, what we got from automatic segmentation quite close to the ground truth model. We take, again, 25 hip radial scans, conduct leave 5 out cross-validation. So basically, the segmentation accuracy in this case, compared to the Cartesian coordinate, is a little bit slightly worse. Its dice coefficient is about 95%. The average surface distance is about 0.77 millimeter. But still, I think it's accurate enough for clinical routine usage. The last work I want to talk about is fully automatic hip cartilage segmentation and dynamic mapping. I think the goal of hip preservation strategy is to preserve the articular cartilage. Biomechanical MRI imaging for cartilage can show changes in cartilage before the tissue loss, but at this moment, most of the analysis are done in 2D due to the reason that we're lacking of an automatic hip cartilage segmentation tool. And if you use manual segmentation, it's very time-consuming and error-prone. So again, this is why we developed the deep learning-based automatic hip cartilage segmentation with anatomical constraint. As you can see, this one is more or less like the last one I presented, but here we put the anatomical constraint. So here again show you actually if with the anatomical constraint, without anatomical constraint, with anatomical constraint compared to ground truth. This is the input data. Without anatomical constraint, you see actually some error, while with constraint, we get much closer to the ground truth. This is another example. Further, another one. So again, we took the MR scale of 24 patients, conducted leave 5 out cross-validation. So we first evaluated the segmentation accuracy. So basically, due to the the very challenge cartilage segmentation, here the dice coefficient is 85%, which compared to the bony structure is relatively low. The average surface distance is about 0.26. We also look at the average cartilage thickness between the automatic segmentation and the manually derived ground truth. So here we get quite good results. The average cartilage thickness difference is about 0.013 millimeter. We also look at dynamic mapping. It's about minus 0.6 plus standard deviation is 8.0. The range for these 24 patients is minus 21.6 to 13.1 milliseconds. So here shows some quantitative examples. So as you can see, this side shows bronchioles. These are automatically. So you can compare the shape and also the dynamic mapping. Another example with different morphology. And further on, another example. You can compare always these bronchioles with automatically. So that's actually finished share the experience with you. So in conclusion, we have developed a fully automatic solution for segmentation of 3D CT of hip with deformities, and also 3D MR images, either acquired with radial scan or normal scan, and also a method for articular cartilage MR images. We achieved a high accuracy in segmentation of bony structures from 3D CT or MR images, but the accuracy for articular cartilage still need to further improve, but actually, if you look at literature, it's equivalent or even better than the state-of-art methods. So finally, I would like to acknowledge my PhD student as well as my clinical partner. They provide all the ground truths for validating this method, as well as National Science Foundation for the funding support, and Professor Simon for his kind invitation. Thank you for your attention.